Yes, Dr. Camp.
Yes, thank you very much. This was really a brilliant session with three beautiful lectures. I really appreciate it. I got a question for Dr. Sandy Go. Thank you so much. It was really very, very interesting. First of all, I want to thank you to emphasize the fact that the fibroid shrinkage lasts still 24 months, which is very important news for the patients and the doctors. My question was, your center is really specialized, and you did train and in this. How many people in your staff are now proceeding with the HIFU? I mean, and how long did it take to train them? When you started from the beginning, so you launched this program, and how many people are working with you now?
Right now we are three
Okay.
doctors doing the procedure. So we were trained by
Okay.
the hypo expert from Chongqing for 3 months, but then we had him extended for 2 more months. So we were trained for 5 months straight. So Dr. Shah, our trainer, had to stay here for 5 months with us. So that whole 5 months, we were doing cases already.
Thank you. Thank you so much. I think this is very important to have this training from the company, and thank you very much. Congratulations.
Thank you, Dr. Decan.
I agree with Professor Decan. It was a very nice session. My first comment would go to Dr. Silva. Congratulations for a really honest and informative presentation. I liked it very much. Your honesty in precautions, cautions about indications. My questions go to Dr. Go. You said that you use oxytocin for reducing the size and the vascularity of the uterus before the HIFU.
Yes.
And this has some logics, but as we know, the gap junctions, which are very much involved in the use in the function of oxytocin, occur mostly during the pregnancy, and those people, those women are not pregnant, obviously. So didn't you also think about other kinds of uterotonics like methylargonovin or something else, or you just use oxytocin? My question has a broader impact on other procedures that we can use out of the pregnancy.
That's what I thought initially also, that oxytocin will only be responsive to pregnant uterus. But then what we have done so far, it's found to be also responsive in non-pregnant uterus. No? So we were trained to use oxytocin, but theoretically, I think you can use other uterotonics also to decrease the vascularity.
You didn't try
But-
other kinds of uterotonics?
But no, sorry.
No, you didn't try other kinds of uterotonics. You didn't try
No.
other, no.
No, we weren't able to try other kinds because that's the most studies that China has
What is-
on oxytocin as a to decrease the vascularity prior to the HIFU treatment.
What is your posology for what is your posology? How do you induce the oxytocin shrinkage of the uterus? How much vials, how much units do you give it per minute, or how do you do it?
How much? We use actually 8 ampules. That's 80 international units in 500 cc.
80.
Yes, that much. So very important. Exactly. So much higher than what we use in our pregnant women. So very important. The
So
whole
80 in one IV.
In-
How long?
in 500 cc.
500.
We run it at 80 cc, and then during the entire treatment, actually, the patient will be on oxytocin drip.
So 80 units throughout half an hour or 1 hour?
Much more. Dr. Sel.
Yeah, there is a formula. These are things that we do and then we forget about it.
Of course,
there is a protocol, and I can't remember exactly what is the rate that but it's through 80 units in a pint, but it is run at a certain rate that is determined by Chongqing, and it's run throughout the cycle. That means we are running it from the beginning to the end. The oxytocin drip is running. I'm sorry, the unit per time, I can't remember the message.
Thank you. Thank you. Thank you.
Yes, Dr. Cruz.
Yes, so I have a question for either Dr. Seb or Dr. So, well, I'm a minimally invasive surgeon, so I'm just wondering if there's any, like we encounter patients who have really large fibroids, large myomas, who are not even good candidates for minimally invasive surgery, be it myomectomy or hysterectomy. So is HIFU when we give GnRH to decrease the volume of the myoma, are there any studies regarding giving HIFU first and then probably delaying the surgery for after 6 months or a year? Have you encountered any of these situations?
Yes, for large myoma,
Huge ones, yeah.
we just have to explain to the patient that there's a possibility that she might need another procedure, meaning she might not just get one session to ablate the myoma. So the patient would then have a choice if she's going to go for another HIFU or go for a minimally invasive, because after the HIFU, definitely the myoma will shrink in size. So at that point, there should be a good discussion with the attending physician as to what other intervention can be done once the myoma would shrink in size. Dr. Selva actually has a lot of experience with doing HIFU,
Combination.
minimally invasive surgery after a HIFU treatment.
I think your question is something that I've been pondering for a long time. I actually don't know what is the physiology of GnRH causing uterine shrinkage. Is it the number of cells become less? Is it the number of volume of the cells becoming less? Is it the interstitial tissue that is becoming less? We don't know. If someone knows, please tell me, because I've been trying to look at this for a long time. The reason why I'm interested in this is we know that fibroids shrink after GnRH. Why does it shrink? Is it, as I told you, is it one of these pathology? Someone done any study? Ask me why I'm interested is, your question is correct because I am a busy doctor. I want to do things fast. If I have a 20 centimeter fibroid, I'll take hours to do it. If I could shrink it to 10 or 8, I could do it fast. But my worry is, will the HIFU treatment be effective? If I can understand the physiology of GnRH, of how it works, then I could make a decision as to whether to give GnRH and do the HIFU. I think there are, Dr. Yang probably has some studies that showed that actually it works better with GnRH and it does work not so good with GnRH. So we actually are in a dilemma as to whether it works. But in my mind, if a fibroid is really big, I don't like to give GnRH analog before treatment because I don't understand the physiology. So if I've got a 15 centimeter fibroid, I will do it without the GnRH. But if it's extremely big, I think it sounds logical to give GnRH to shrink it and then do. But I'm always fearful whether it will be as effective as it is without GnRH. You understand the question? So, but for adenomyosis, it's a different ballgame. I don't like to give GnRH. One of the other disadvantage of giving GnRH analog is in multiple fibroids. I have had this experience that a patient was given GnRH analog before multiple fibroids, and when she came to me, all the small fibroids have disappeared. So I was ablating only the big ones, and she went back 3 months later. The smaller ones have grown back, so I have to do a second HIFU. So if multiple fibroids, I think it's not a good idea to do GnRH analog because you want to try and kill as many while they are there and not make them shrink. Okay, as for adenomyosis, I actually don't like to give GnRH analog before the treatment. The reason being, when we do adenomyosis, we need margins. We need 1.5 centimeter margin from the serosa. We need 1.5 centimeter margin from the endometrium and try to ablate in the center. If you shrink it, I've got less tissues to burn, to ablate, especially the smaller ones. So I rather do it with what they are. As far as fibroid, you have a capsule. The energy is kept within the capsule. Whereas in adenomyosis, you don't have a capsule. It can go anywhere. So I rather have the uterus big, and I have got more tissues to burn, and I've got a safety margin when I do for adenomyosis. So that's my explanation for the use of GnRH before HIFU.
But HIFU before the surgery.
Before doing,
Yes, that's what
I do it all the time.
You do it all.
I do it all the time. I do a lot of laparoscopic surgery, and all my patients. In fact, I started doing it because I want cases to do laparoscopic surgery, not because I wanted to do HIFU. So because I see a lot of patients with huge fibroids, which we cancel HIFU, I usually give GnRH to shrink them to do, because my surgery becomes faster, although the margins become difficult. The traditional teaching is you cannot get the exact margin to get the fiber out, but despite that, you can enucleate, and the biggest problem is morcellation. You have a huge amount of tissue to morcellate. So if it's shrunk, I take a shorter time to morcellate. So if a fiber than 12, 13 centimeters, I will give them GnRH to shrink it before I do the myomectomy.
Thank you.
Okay, to Dr. Shi, you've been doing focus ultrasound on intraepithelial neoplasias of the vulva, vagina, and the cervix, right? So have you been doing focus ultrasound on malignant lesions also of the cervix, vagina?
就是那个有没有做过有关恶性的宫颈的那个疾病？对。So we haven't done the malignant tumor on cervix yet, but maybe later we will do some research.
Thank you.
Thank you.
Also on cases of recurrences after chemo radiation, none yet.
就是化疗以后复发的那个，也没有做过。No, even no.
Okay. Thank you, Dr. Shi. Do we still have other questions from the audience? Yes, Dr. San Juan.
I'd like to congratulate Dr. Shi for that very innovative treatment of CIN1 and 2. That's the precancerous lesion of the cervix. Usually when we see CIN2 in a pregnant patient, we wait until she delivers. But what about, but I found out that in your results, you had a higher cesarean section rate. What was the reason for the cesarean section? The cervix did not dilate? Was there more fibrosis in the cervix that it did not dilate during delivery? This is about 63% cesarean section. Because when we encounter CIN3 or even CIN2, the treatment is a lip procedure, but we don't do it because during pregnancy it's very vascular. The cervix is very vascular. We encounter a lot of bleeding, and because of the possible cervical incompetence, which will cause premature labor. But in your case, it's the opposite. When you applied the high intensity focus ultrasound on the cervix on the CIN1 and 2, you did not encounter a lot of abortions or premature labor. Maybe there was no cervical incompetence because you did not resect a part of the cervix. But I'm just asking why there's an increased rate of cesarean section. Was it because of the cervix not dilating during delivery?
Sorry，他是问就是我们治疗那个宫颈以后，它的那个剖宫产率就是偏高。他问是这个什么原因？是因为那个我们宫颈的扩张不太好了吗？还是什么原因？就是我还是做中文，帮我翻译一下。就是他看到有一篇文献是吧？是那篇文献上面，他是说的是做了以后的剖宫产率要稍高一些，但是那篇文献里面后面还补充说明了一下，就是其实中国的剖宫产，它很多和病人就是社会因素是有很多关系的，就是他可能是担心这个
有问题，所以说就主动去要求，而不是说这个病情发展到必须要去剖宫产。然后当时那篇文章是把这个因素排除了以后，其实它的剖宫产率和正常的一般的女性是相当的。
Actually, I answer this question. So first, I would like to say thank you for your question. Actually, for the we use a focus ultrasound to treat cervical diseases. Actually, they compared the safety and effective efficacy for the other, like the lip and also some other treatment. You consider about like the cesarean section rate. You know, like I just answered, in China, the cesarean section rate was very high because once we hit the one-child policy, so usually at that time, for the ladies, they went to the hospitals for the safety reason. Our doctors always suggest to have the cesarean section rate even for like ultrasound for the cervical diseases, for the cesarean section, not just because they have the indication for cesarean section, just because of social factors.
So I understand. Thank you.
Thank
I
you,
thought
thank
it was because of the complication.
Right.
So it means that
Yeah,
there was
it's a lot.
no complication causing a lot of cesarean section. Thank you
Right.
very much.
Thank you. Thank you.
Hi, thank you very much. Excellent conference. I have one question. Why they use antibiotics in this procedure? Because I think, of course, for the myoma type 1 or 0, but in the other myoma, you use antibiotics too? Because you use in the protocol, they use antibiotics.
The antibiotic, the use of antibiotic.
In your protocol,
Yes.
you use your antibiotics.
It-
Why?
It
Why
was, usually we were told to use antibiotics, especially for submucous myomas, because there's going to be swelling around the myoma, which will interrupt the lining, and patients would have sometimes spotting and bleeding, and they're going to be prone to infection. So that's the reason why we usually give it, especially for the submucous type.
Okay, but for all patients, for example, for the myoma 3, 4, or only for the myoma in submucosal myoma?
More so for the submucous type, but depends on the case.
Okay, so thank you. This ends our Q&A for this session. So let me call on Dr. Severino for the next session.